she's currently the Chief of Cardiac Imaging. So I think it's a really warm welcome to you. I think you would be the best person to teach us the clinical and the radiological thing and what really matters. So I think it's going to be the most exciting session. Thank you for accepting the invitation.
Thank you, Dr. Huja, for that very nice introduction. I very much appreciate it. And the honor is all mine. I'm very excited to be here this morning. It's quite early here in Portland, Oregon. It's about 6:30 in the morning, but this is
Oh,
great. I'm very excited to be speaking to
so
all of you.
again, a real thank you for being up so early for all of us. So thank you so much.
Absolutely, absolutely. So I'm going to give this talk, chest imaging cases and pearls. And, I very much, I like this presentation style in terms of cases because I think it can help the viewers remember a lot of these cases, as opposed to just telling you facts about different things. And these cases that I picked, I actually have 6 cases in here. They're cases that I think are good to talk about because they're things that you may not think about very often, but they have a very large impact on the patients that you're seeing. So that's why I chose these 6 specific cases. And then just before we start out with the cases, I'm just going to talk a few minutes about some terms and a little bit about contrast. If there are questions along the way, absolutely feel free to ask questions. I can't actually see the chat box while I have this lecture mode up. So, Dr. Ahuja, before I finish each case, feel free to, mention any questions, or I can address them at the end, whichever way you think. Now, this lecture may go a little bit over 45 minutes. So if you all have extra time, I can continue. Otherwise, we can cut some of the cases short. Okay, so let's go ahead and get started. I just am going to put this very brief slide in here that this is in part sponsored by the Society of Thoracic Radiology, of which I'm a member of and very active in this society. So the Society of Thoracic Radiology is an American society that's dedicated to lifelong learning of cardiothoracic radiologists and other health professionals to advance medical care in radiology in all disciplines. And so specifically, one of the missions of the STR is to promote cardiothoracic imaging worldwide. And that's part of why I'm here today. So thank you again for having me. So I want to just start out with talking about words not to use in a radiology report. And the reason I wanted to start this lecture out this way is because as radiologists, the most powerful thing that we have is the words, right? So if our clinicians can't understand what we're saying, then even if we know what the images show, but we can't convey that information correctly to others, then you lose all of your ability to be able to actually treat your patients. So these are a few words that I'm going to discuss that commonly are used that should not be used in reports. So the first one is infiltrate, right? We hear that word all the time. And this is an example of a chest CT where you might say, oh, this patient has an infiltrate in the lungs. And it was a very commonly used word. But according to the Fleischner Society Glossary of Terms for Thoracic Imaging, published in 2008, they recommended that this word not be used. And basically, it's a term used to describe a region of pulmonary opacification caused by airspace or interstitial disease seen on radiographs and CT scans. But the reason it's controversial is because it means different things to different people. And so they recommend that it no longer be used, and instead the word opacity with relevant qualifiers is preferred. And we'll talk about that in more detail. Another word that's commonly used, or another phrase, is airspace opacity or interstitial opacity. And a lot of times people will use that term when they're looking at chest x-rays, and they'll say it looks like there's airspace opacities or interstitial opacities. But when you stop and think about it, if you're looking at a chest x-ray, you don't have a microscope, right? So you don't know if the opacity is only limited to the air spaces or if it's also involving the interstitium. And chances are it's involving both areas. And so that's a term that personally I prefer not be used. And instead, we focus more on a pattern-based approach. So do you see consolidative opacities, ground attenuation, you use more of the pattern to describe the findings rather than the location within the lungs, because most of the time you can't be absolutely. Another term that, at least in the United States, that I commonly see being used by residents and attendings, faculty alike, is reticulonodular. And that's often a term that I see described either on x-rays, but more commonly on CTs. When there's a lot of different findings, people may tend to say it looks like there's reticulonodular opacities. And, it's funny because when I hear that term, I don't actually know what that means. So we know that what reticulation is, and I'm going to show you an example of reticulation. We know what nodules are, but reticulonodular, you don't see that combination very often. It's extremely uncommon to see that. And it's become almost this term to use where you see things in the lungs, but you're not quite sure what it is. So then people will just say, looks like a reticulonodular pattern. And so I would try to avoid using that term because it's not actually clear what that is. And reticulation and nodules often don't occur together very commonly. So we'll talk more about what you should use momentarily. And so I always joke that reticulonodular is for rashes, because it's kind of like, when you dermatologists see patients in clinic, they use different words to describe rashes. And one of the terms that non-dermatologists always use is maculopapular. If you don't know what the rash is, we always say it looks like a maculopapular rash. And this term reticulonodular reminds me of it. If you don't know what's going on, people just use this term. So I would try to avoid using that term. And the last word, and I don't know how common this is around the world, but is fields. And that's one of the terms that I hear a lot of clinicians use when they're describing findings in the lung. They'll say in the left lung field or the right upper lung field. And so we always use this joke that we say fields are for cows, right? You graze in a field, but fields are not to be used in the lungs. And we want to stick to using medical terms. And that's important because when you're trying to convey information to other clinicians, you want to make sure that that they understand exactly what you're talking about. So you try not to use non-medical terms. So now the question is, what words should you use to describe each of these different things? And let's talk about that very briefly. The most important term that's important to understand is the word or the term opacity. So opacity is basically when you have increased attenuation of the lung parenchyma, right? So if you look at the CT scan here, you'll see that there's increased attenuation here throughout the lungs. Now we can qualify that by saying there's ground glass opacities. So if you look at this specific area here where I have the blue area, this is what I would call a ground glass opacity. And what ground glass specifically refers to is that you have increased attenuation, right? So this is normal attenuation. And then here we have increased attenuation with indistinctness of the blood vessels or architecture. So I can still see some of these blood vessels going through. I can still see some of the airways, but they're just very indistinct. So I would call this a ground glass opacity. Now contrast that with consolidation, in which you have complete obscuration of the blood vessels and the airways, right? You can't see any of the blood vessels or airways here. So this is what's called a consolidative opacity. And this is what's called a ground glass opacity. And think about how much more useful that is if you're talking to a clinician on the phone and you're describing what's going on in the patient's lungs and you say, I have a ground glass opacity. They can now imagine what that looks like, as opposed to saying there are infiltrates in the lung. So try to use these words. Now, if you don't know if it's ground glass or consolidative or it's a mix, you can just use the word opacity alone. But if you can tell clearly whether it's ground glass or consolidative, I would use one of these terms. And then the reason it becomes helpful is because then you can make your differential diagnosis based on whether it's consolidation or ground glass. A couple other terms that are important to understand clearly and therefore use correctly. One is nodule. So a nodule is defined as a focal area of increased density that's less than or equal to 3 centimeters. So for example, when we see this here, this would be described as a nodule, a spiculated nodule. It measures 8 by 8 millimeters, so it's less than 3 centimeters in size. And that's different from a mass, which is greater than 3 centimeters. So if we saw this finding, this focal area of increased density, specifically a consolidative density, it measures 4.5 by 5.2 centimeters, we would call this a pulmonary mass. So you really want to differentiate nodules from masses based on their size. And then the final word that I just want to mention is reticulation, because it is important to know when to use this, because we see this very commonly. So reticulation refers to irregular linear opacities, typically in a lace-like network. So here's an example of reticulation, and you can see it's present here in the periphery. So we would call this subpleural reticulation. And this is when you have these crisscrossing overlapping lines. And this is different from pulmonary edema, where you might have those hexagons from the secondary pulmonary lobule. These are just very irregular crisscrossing lines that often happen in the periphery, and they're seen most commonly with interstitial lung disease or pulmonary fibrosis. Okay, so now that we've gone through that, let's just very briefly talk about contrast in the chest, and then we're going to move on to our cases. So the first question really about contrast is, when would you order a chest CT with contrast? And I think this is an important point to make, because a lot of times, clinicians may not know, well, should I order contrast in this patient or should I not? And if you're reading a scan that should have required contrast, you're not going to be able to provide the information or the answer as to what's going on in the patient. Or conversely, they may order contrast when the patient might have borderline renal failure and the contrast was a waste, because you would have been able to make the diagnosis even without the contrast. So situations in which it's very helpful to get contrast on a chest CT is when you're trying to work up pleural disease. So if the patient might have an exudative effusion, such as in the setting of a pneumonia or an empyema, getting contrast is very important, because it allows you to see whether or not there's an enhancement of that visceral and parietal pleura, which can help you characterize it as an exudative effusion or not. And then also, a lot of times when you have contrast in that setting of an effusion, you can see if there's nodularity along the pleura within the effusion, which might indicate that potentially I'm dealing with a malignancy. So working up pleural disease, giving contrast is always helpful. Another situation in which contrast can be helpful is when you have a mass, like that case I just showed you with the mass. If that was abutting the mediastinum or the heart, it can be very helpful to give contrast. And the reason why that's helpful is because without contrast, you'll still be able to see the mass in the lung parenchyma, but you may not be able to accurately measure it, or you may not be able to tell whether it's invading through the mediastinum into the heart or into the pericardium. So having that contrast can really help you sharply delineate the margins of the mass, and to better evaluate invasion into either structures like the mediastinum or even into the pulmonary arteries or pulmonary veins. Another situation in which contrast can help is if you're trying to measure the size of hilar or peribronchial lymph nodes. Now, depending on what slice CT scanner you have, some of the CT scanners these days are very, very good, and you can clearly see the hilar lymph nodes without contrast. But oftentimes, especially depending on the size of the patient, it can be tricky to measure the size of the hilar nodes. So if you're trying to determine if a patient has sarcoidosis and you want to know if the hilar lymph nodes are abnormally enlarged, sometimes contrast can be helpful in this setting, or if you're working up a malignancy. But in that situation, it's not always required. And the final situation is patients that have an opacity in their lungs, typically a consolidative opacity, and you're not sure if it's a pneumonia versus atelectasis. And we're going to talk about that in more detail, so I'm going to hold off on mentioning other details. When would you not want to order contrast in the lungs? And the most obvious situation is when you're working up lung nodules. So if a patient, you're getting a CT to either look for lung nodules, or if they had a lung nodule in the past and you want to follow it up, you don't need contrast. And the reason why is because the lungs are aerated with air. And that is the inherent contrast within the lungs. So the aeration, the dark attenuation of the lungs surrounding the nodule provides contrast between the nodule itself. So you don't need contrast to work up pulmonary nodules. You also typically don't need contrast to look at mediastinal lymph nodes. And again, this is going to depend on how good of a CT scanner you have. You know, if you have a CT scanner that's going to be over 32 slices or definitely 64 slices, you should have a good enough scanner to be able to look at the mediastinal lymph nodes without contrast. And almost all of our cases, we don't order contrast in that setting, unless, of course, we're concerned about malignancy and that potentially there may be more lymph nodes in other places. But usually we start out with a non-contrast. And now this list, I want to just emphasize, is not exhaustive. I just want to mention some of the more common reasons to get contrast. And this, of course, does not include vascular reasons, which are, you know, to look for a pulmonary embolism or to look for an aortic dissection. This is kind of more parenchymal reasons that we're discussing. Okay, so now let's go ahead and dive into our cases. Usually when I've given this lecture in the past, I'll have a resident and I'll have them taking cases. But for the purposes of time, I'm just going to kind of go through these cases with you. And I'll talk through how I would look at these cases and how I would think about them if they were coming to me at my workstation. All right, so the first case is a patient that is presenting with new onset hypoxia. And I'm giving you very limited information because I'm not sure how it is for you, but when we get x-rays and CT scans, we usually only have, you know, one or two words, typically. Occasionally we might have a whole sentence, but I really like to think about the fact that the majority of the time we have very limited clinical information. And so in this case, this was actually more than I would have expected to be provided. And so how would you approach this case? So this is the radiograph that was presented, right? And this is the patient today, and they're having new onset hypoxia. One of the things that I can't emphasize enough is when you're looking at any imaging, always have your prior up, right? And chest x-rays are great because when you're looking at the lungs, the nice part about the lungs is you have two of them. So immediately you have something else to compare to. You have potentially a normal side, but then also comparing to the prior is probably one of the most helpful things. Now, when I look at this x-ray, here's the first thing that I do on most x-rays. I usually compare one side to the other to look for symmetry or asymmetry. And the first thing you'll notice, or that I would notice on this x-ray, is that I definitely have marked asymmetry between my two lungs for two reasons. The first is that there's increased attenuation throughout the lungs here on the left side compared to the right. You know, you can see that the right lung is much darker than the left lung. So clearly one side or the other is abnormal. I haven't decided which side, right? So this could be the abnormal side, or this could be, you know, when you think about your typical ICU patient, they usually have low lung volumes and increased attenuation. So I don't want to exclude the fact that this could be the abnormal side, but I definitely know that one or the other is abnormal. The other thing that I notice is that the volume on this side is much smaller than the volume of the lungs here, right? So normally your left hemidiaphragm should be lower than your right hemidiaphragm. The right hemidiaphragm sits higher because the liver is below the hemidiaphragm. So when I look at this, there's essentially two observations I'm making. There's increased attenuation and there's a lower amount of volume in the left lung compared to the right. Now, when I look at the x-ray from yesterday, I can clearly see that the change that has happened between yesterday and today happened in the left lung. So now that's going to increase my pretest probability that this is actually the abnormal lung. So when I look at this, there's two possibilities that I can think of. If I've decided that this is likely going to be the abnormal side of the lung, I have to decide, is this a space occupying process, right? Is this something like pneumonia or hemorrhage within the lungs that's occupying space and making my lung turn white? Or is this a volume loss process where I have atelectasis and now my lung volume is lower and that's what's making my lungs turn white? So the best way to figure out if you have a space occupying or a space loss process is to look at a couple things. So one we talked about was the hemidiaphragm, right? If I had a space occupying process, I would expect my hemidiaphragm to actually be lower, not higher. The other thing you can look at is mediastinal shift. Now, in this case, the mediastinum actually looks, the trachea actually looks relatively midline. And when you compare it to yesterday, it's possible that we may have very slight leftward mediastinal shift when you look at these vessels here, but that's a little questionable. But the other thing you can look at is the rib spaces. So when I look at these rib spaces, look at the distance between the ribs that you see here, right? Now compare it to this side. See how close these ribs are? That really emphasizes the fact that I have a volume loss process that's going on. So now if we get into the nitty gritty of it, you can see that the left main bronchus is much more horizontal than yesterday. And this is the normal appearance of the left main bronchus. The left lower lobe bronchus has a much more vertical orientation compared to yesterday. And the most important finding that you may notice is that the patient is now intubated. So I don't know if people are able to kind of put into the chat, but I'm curious if anyone has a thought as to what the diagnosis is here. And Dr. Ahuja, if you see any of the answers in there, maybe you can just share them out loud. Okay,
So there are quite a variety.
Say that again.
So there are quite a variety of options which people have put in. So left upper lip collapse, foreign body obstruction, ET blocking the left main bronchus.
Okay, wonderful. That's perfect. So this was actually a case of left upper lobe collapse. So for those of you that got that, excellent job. And this is a very hard case in some ways if you're not thinking about this diagnosis. But really the key here was noticing that when we look at this, is that this change happened in one day. So it's very acute. And we can see that the patient got intubated. And so even though this endotracheal tube doesn't look like it's in the right main bronchus, this was immediately pulled back and the x-ray was taken. And this was the sequela of left upper lobe collapse. So with left upper lobe collapse, you'll see this veil-like opacity in the lungs. You'll see that horizontal left main bronchus that I discussed. Right there, you can see with the arrow. And then the volume in the left lung is going to be decreased overall for all the reasons that I described, that was the new finding compared to yesterday. Another finding you can look for that I'm showing you here is what's called the juxtaphrenic peak sign. And this is basically where you have peaking of the diaphragm. And whenever you see the juxtaphrenic peak sign, always look at the upper lobe on the same side of the x-ray, because that indicates that you may have upper lobe collapse. Or at least upper lobe volume loss. And this applies to both sides, even in the right lung. If you see a juxtaphrenic peak sign, look in the right upper lobe to see if you have volume loss or collapse. And then one of the most characteristic signs that you'll see in left upper lobe collapse, if you are lucky enough to have a lateral x-ray, this is a very characteristic appearance. You'll see this straight line going down and this increased opacity. And if you aren't familiar with this, you'll look at this and wonder, is there a mass there? What is this? And this is the characteristic appearance of left upper lobe collapse on a lateral x-ray. Okay, so I know that there's there's hands that are being raised. I'm curious if you think based on time, if we should take questions or if I should just keep going through the cases.
I think let's take questions at the end of the session, I think.
Okay, perfect. Let's do that. Okay. And then one other point I wanted to make on here is one thing that's associated with left upper lobe collapse is what's called the Luftsichel sign. So a Luftsichel is actually a farming tool, and it has this appearance to it, right? This kind of like sickle shape. And so you can see the Luftsichel sign in left upper lobe collapse. So you see it right here. And when you see that, that can also be a clue that you have left upper lobe collapse. And it's due to the fact that there is the aerated superior segment of the left lower lobe that's interposed between the aorta and the collapsed left upper lobe. Now, it doesn't have to be there, but if you see it, that's another clue that you may be dealing with left upper lobe collapse. Okay, so now let's move on to case 2. I'm going to just move this out of the way. Hopefully this is not obscuring the x-ray. So this was a patient that had new fever with shortness of breath. And this is also a patient in the ICU, of course. You can see that the patient is intubated. They have an enteric tube. They have a central venous catheter that's present. And the most important thing you can do is compare one lung to the other and comparing the whole radiograph to the most recent prior radiograph. And what you see is that since the prior radiograph, there's been interval development of these new opacities that are present in the lung. And when we look at these opacities based on the terms that we described before, it looks like there's more ground glass opacities in actually both upper lobes or both upper hemithoraces. We don't know if it's just the upper lobe or if it's the middle lobe as well and the lingula. But there's ground glass opacities present right side greater than left. But more importantly, what you'll notice here is that there's also increased opacities. And in some of these areas, it looks like it's actually obscuring the underlying architecture of the lungs. So maybe we have some degree of consolidative opacities present in the right lower hemithorax. And that's definitely new since the prior exam. We do have a small left pleural effusion that's present and that's been present, and maybe some retrocardiac atelectasis because it's very dense here. Now, this patient, given the history of fever, they're in the ICU. The question is, what is going on with this patient in terms of, do they have a pneumonia? Did they aspirate? This patient actually ended up going for a CT scan because there was concern about an intra-abdominal source. And so because the patient was being scanned for an abdomen pelvis, they were in the ICU and they had these new opacities. They ended up doing a chest abdomen pelvis, CT. Now, the reason I'm mentioning this is I'm going to show you the CT scan, but just looking at the X-ray alone, it's not that you need a CT scan to work this up, right? So if the patient had fever, they had increased sputum, and you knew that they, were having a radiograph that showed evidence of potentially a new pneumonia, you could treat them based on just that information alone. And if, let's say, if they had a fever, you knew that they aspirated and then the fever goes away, that may just be an aspiration pneumonitis. That may not require treatment. But if you have a CT scan or you know that the patient's going to get a CT scan, the question you want to ask yourself is, would it be helpful to give this patient contrast if I'm going to do a CT scan? And the answer is going to be yes, because I mentioned earlier that if you're trying to decide between atelectasis and pneumonia in the lungs, giving IV contrast is very helpful. Now, let's take a look at this patient's CT scan. So this is the scan that we received, and I want you to just take a look at this for a moment. And you can clearly see that there are opacities present in the lungs, bibasilar opacities that are dependent. And you can see that the patient actually has bilateral pleural effusions. They're both small, but just greater on the left compared to the right. And now the question I have is, I'm going to tell you that one side was atelectasis and one side was pneumonia. And I want you to look at this with the contrast and figure out which side is atelectasis and which side is pneumonia. Okay, and this is the clue here. So one thing you can do is you can look at the Hounsfield units of the actual opacities. So if I were to draw a Hounsfield unit inside here, and then also in the paraspinal musculature, these are the different Hounsfield unit values that we get. So I'm going to tell you that the answer is, let's see if I have the answer here. No. Okay, so I'm going to tell you that the answer is this. This was atelectasis. This was pneumonia. I'm sorry, I missed what you said.
So again, we have a mixed response. We have quite a few left and quite a few right.
Okay. And so let's talk about why it's each one. So when you think about atelectasis, it's normal lung parenchyma that's just compressed together. So when you give contrast in a patient that has atelectasis, the contrast is going to very easily flow through all of the vessels, right? Because you don't have hypoxic vasoconstriction. I mean, the contrast is going to flow through there normally, and it's going to be brightly enhancing. Atelectasis will be. So if you look at the Hounsfield unit value of 131, that's very bright, and that would indicate that it would be atelectasis. And typically, atelectasis is enhancing much more than normal paraspinal musculature. When you think about pneumonia, inside of the airways, you have pus and debris and secretions, and that is going to significantly decrease the attenuation of your lung parenchyma. Now, you may still have a normal amount of contrast going through, or you may have some degree of hypoxic vasoconstriction in that area. But for both of those reasons, the attenuation of the lung in the setting of pneumonia will decrease. And when you have necrotizing pneumonia, where it's actually like infarcting the tissue, it can actually become water density, so under 20 or close to 0. But oftentimes pneumonia will have an attenuation lower than paraspinal musculature. But clearly you can see the difference in attenuation between these two lungs. And with the contrast, you can see how dark this lung looks, especially compared to this side. So even if you didn't measure the Hounsfield unit values, just qualitatively, you can see how dark this looks relative to the other side. So this is why contrast helps, because if you didn't have the contrast and you just saw bibasilar dependent opacities, it's possible that this may just look like bibasilar atelectasis secondary to adjacent pleural effusions. But now that we have the contrast, we can more confidently look at this and say, yes, this looks more concerning for pneumonia or aspiration. And that's exactly what this patient ended up being treated for. So the point is that when you're differentiating atelectasis from pneumonia, contrast helps. Atelectasis should be hyperattenuating relative to paraspinal musculature, and hypoattenuation suggests consolidation, whether that's from pneumonia, aspiration, tumor, whatever the cause. And when you have severe hypoattenuation, that suggests necrosis. Okay, so let's move on to case 3. So these are x-rays from 2 different patients. I'm not going to give you the history, but when these patients came, they were asymptomatic at presentation. And I want you to just look at these and in your mind, just decide which radiograph you might be more concerned about when you look at these. I'm going to give you just a second to look at this. So I'm sure you've noticed that the abnormalities are in the right hemithorax, specifically in the right upper hemithorax. And here you see multiple lucencies that are present. Maybe this looks concerning for cavitations in the right upper lobe. And when you look here, you see what looks like bronchial thickening here. Maybe there's a cavitation here. It's tough to tell, but it certainly doesn't look as striking as the radiograph in patient 2. But there's certainly, focal opacities here with bronchial thickening and some degree of abnormality here. So looking at these 2 x-rays, you might think, well, this one looks more concerning because I have what looks like more claricavitary lesions. Perhaps this patient has tuberculosis. Perhaps they have a malignancy. So let's take a look at the CT scans and see if this helps us. So when we look at the CT scans, which I've shown you here on coronal images, now you can very clearly see what the abnormalities are. And now you might ask yourself, which CT scan is more concerning? Well, if we look at patient 2, we definitely see this large cavitary lesion in the right upper lobe. There's also an adjacent cavitary lesion. There are a couple nodules that are present, but it's very well demarcated here. And clearly you can see that, well, I shouldn't say clearly, but this patient did have some degree of volume loss here. When we look at patient 1, we also see that these abnormalities are predominantly in the right upper lobe. You can see that minor fissure. And what you see here is all of these areas of bronchial thickening surrounding these small airways here. There's definitely tree and bud nodularity that's present. And you see this opacification here. Perhaps this is an airway that's completely plugged up. There's certainly a degree of bronchial thickening. Maybe this is an early cavity, but it looks more like bronchial thickening and then occluded airway here, but a lot of tree and bud nodularity. So now the question is, which one is more concerning? And if I were looking at this, the one that I would be more concerned about would be patient 1. Okay, so now let's talk about this.
Hi. So there was a mixed response, but predominantly people chose patient one as the more concerning
Excellent.
radiograph status. Yeah.
Okay. Well, I should even be, you guys should be teaching this lecture because that's very impressive. Typically, when I've given this, most people choose patient two because they see this large cavitary lesion. So it's very impressive that you would look at the tree and bed nodularity and think this is going to be more concerning to me. So let's briefly talk about a differential diagnosis for cavitary lesions. And I think this is important to talk about briefly because depending on where you are, what part of the world you live in, people automatically gravitate to one diagnosis that they say, oh, of course, I'm concerned about this. So you might think, well, of course, this is going to be tuberculosis, or of course, this is going to be a squamous cell cancer, or of course, this will be a fungal infection. So it's important to consider all things whenever you see cavitary lesions. So cancer is a very important one, right? So lung cancer, and particularly squamous cell lung cancer, loves to cavitate. So important to think about that if you have a patient that is a smoker, let's say, and is presenting with weight loss, doesn't have any fevers or night sweats, but has weight loss, maybe is having some hemoptysis, consider that diagnosis. Autoimmune diseases, if you're thinking about potentially a middle-aged female that has known underlying autoimmune disease, this might be something, or GPA, which might be seen in younger patients, in 20 to 40-year-olds. And especially if they have acute onset symptoms, that's another thing to think about, which can cavitate. Septic emboli is another one. So if you had a patient that was an IV drug user and presented with cavities, particularly if they were in the lower lobes and they were more peripheral, you want to think about septic emboli. Infection, of course, is a very big category. So tuberculosis, fungal diseases, NTM, bacterial lung abscesses, nocardia. These are all different types of infections that can cavitate. And I always say that whenever you say the word TB, you should always say fungal right after it. Diseases that look like tuberculosis can also look exactly like fungal diseases. And those two kind of go hand in hand with each other. And NTM is also one, to consider depending on where you live in the world, how common that is. In the United States, we see it very commonly. I see non-tuberculous mycobacteria every single week. So these are all various different types of infections. Obviously, this is not an exhaustive list, but just common ones. And then trauma. So if you know your patient had a history of trauma and presents with this cavitary lesion or has had a trauma in the past, perhaps this is a post-traumatic pneumatocele. Or let's say you're dealing with a child or somebody that's totally asymptomatic. Maybe they have a congenital abnormality, such as congenital pulmonary airway malformation, which can present with cavitary type lesions. So the diagnoses for these patients are listed here. So patient one actually had tuberculosis, and patient two actually had non-tuberculous mycobacterial infection. So patient two was actually chronically colonized with NTM. They were asymptomatic. We were finally able to get their scans from 3 or 4 years ago, and it looked exactly identical. And this patient didn't have any symptoms, so wasn't treated for NTM, and they were completely stable. Patient one was presenting with new onset fevers, night sweats, weight loss. And now you might ask me, why was I more concerned about this patient CT compared to this patient CT? And the point that I was trying to make here is that let's say if both of these patients had tuberculosis, the reason this one is more concerning is because this patient has tree and bud nodularity and bronchial thickening. And what that indicates is that this patient is actually contagious. So all of the stuff that's here is all within the airway. So if this patient coughs, they're going to cough out those TB particles everywhere. Whereas when you have well-contained, sealed off cavities, it's less likely for that to happen. Now, I'm not saying this patient wouldn't be contagious if they had TB, but this is the one that looks more concerning. And so, of course, looking at tree and bud nodularity is the finding that would be more suspicious. But the overall point is that these diseases can look very similar. So depending on what the clinical history is, what the demographics are for this patient, this was a elderly female. I think this was a young male or female, but essentially the clinical symptoms and the demographics can really help you. Okay, I know we're running very short on time, so I'm going to just kind of go through some of these cases a little bit more quickly so I can expose you to some of them. But we talked about cavitation, and so I'll just kind of click through this. This is one case that I wanted to bring up because it's a situation that may not be commonly known. And we see this very, very commonly. So this was a patient that had known COPD, chronic obstructive pulmonary disease, and they completed a steroid course and they were presenting with persistent dyspnea. So we see patients like this all the time that will have chest x-rays, chest CT scans, and they're completely normal. And the clinician will give them steroids and they will say, well, I maybe felt a little better, but I still feel very, very short of breath. And the clinician is wondering, well, what should I do? Should I get another CT scan? They might call you up and say, to the radiologist and say, well, should I just get another CT scan? And they might ask you, what should I do? And one of the things that's very important to consider in this case is you might ask, well, what's the next step? And well, this would be a good option for a next step, is an paired inspiratory and expiratory CT. So when you hear that history, this patient's been given a diagnosis of COPD, or perhaps they have, they appear very similar to patients that might have COPD, like a former smoker, and they're just having persistent dyspnea with or without steroids. Getting an inspiratory and expiratory paired CT can be very helpful. So this was the patient's original inspiratory CT, and these two are the expiratory CT. Now, there's a couple observations that you'll make. So one, when you look at this expiratory CT, you'll notice that this part of the lungs has increased attenuation, and this part of the lungs has lower attenuation. So in an expiratory CT, the patient breathes all the way out. So everything should turn whiter, right? Everything should look like this. But that didn't happen for this patient. And so what that indicates is that this patient is having severe air trapping, which can cause that feeling of shortness of breath. And so now when we look higher up in the lungs, look at the trachea. Do you see this trachea? It has completely collapsed. So when they breathe out, no air can exit through the trachea. And what you'll also notice is that there's extensive thickening of that cartilaginous portion of the trachea, which you can slightly see on the inspiratory phase now that you've seen the expiratory phase. And so this was a patient that had tracheobronchomalacia. And so tracheobronchomalacia is a very underdiagnosed disease. And the clinical symptoms that you classically will see is persistent shortness of breath or a chronic cough that doesn't respond to steroids. And the way that you diagnose this is by getting a dynamic expiratory phase CT, or you can bronch the patient. So a dynamic expiratory phase CT is where they do the inspiratory phase just like normal, and then they do a second CT, and it can just be a short section, or you can do the whole chest. But basically the patient is breathing out, and while they're breathing out, they do the CT scan. And while they're breathing out, the trachea collapses. And there's various forms of tracheobronchomalacia that I won't get into just because of time purposes. But essentially the key is that you have greater than 70% collapse of the trachea on expiration. And so again, I'm going to just kind of skip this part of it because these are getting into the more nitty gritty. Whereas the point I want to make is that you should consider tracheobronchomalacia in this setting and potentially recommend it to your clinicians if you have patients that have persistent shortness of breath or chronic cough and all of the CTs appear to be normal. And, with tracheobronchomalacia, there's no definite treatment. They can use nocturnal BiPAP, which can help. Sometimes patients do get stented. That isn't very common. There's very specific indications for that. But the most important thing to remember is that steroids worsen the problem. And usually these patients are given steroids because they're thought to have asthma or COPD. But steroids actually make that membrane weaker and worsen the problem. So that's why diagnosing this is important. Okay, so keep tracheobronchomalacia in mind. Case 5 is a patient that presented with shortness of breath. This was a patient in the ICU. So this was a portable radiograph, and it's a supine radiograph. And I want you to just take a look at this radiograph. I think this is one of the most important cases. And if you get a chance to be able to put your diagnosis in the chat, I'll give you about 10 to 15 seconds to look at this. And then if you're able to tell me what you think this diagnosis is. This was new onset shortness of breath. Okay, do we have any diagnoses listed in the chat?
Yeah,
And
people
yeah.
have called it deep sulcus sign, right pneumothorax, uh, and yeah, most of them have called right pneumothorax with deep sulcus sign.
Okay, excellent, excellent. So this is the patient's prior radiograph, and that's really the most important thing that you can look at is, well, what did the prior look like, right? And so when you look at the prior, you can see bilateral hemidiaphragms and what they look like. And on this radiograph, that's exactly right. You see a deep sulcus sign here, right? So the hemidiaphragm, is going much lower, and you see this area of increased atelectasis here. And the key is that this is a supine radiograph, which is a situation in which you see this deep sulcus sign. So let's talk about this. So this is a patient that, as you mentioned in the chat that most of you got, was a pneumothorax with a deep sulcus sign. The reason why this is an important diagnosis to not miss, because of course, this patient has a tension pneumothorax, and we're going to talk about more details about this in a moment. But oftentimes when they do radiographs in the ICU, oftentimes the technician may cut off the radiograph right here. And it's really important when you have a patient presenting with new onset shortness of breath, new onset hypoxia, and it's a supine radiograph, you want to make sure that they're including the area below the hemidiaphragm so that you have the opportunity to look for this deep sulcus sign. And this is a classic sign that you'll see with a pneumothorax. So now let's talk specifically about a tension pneumothorax. So what do you look for in a tension pneumothorax? So one thing you look for is mediastinal shift, right? So if I just go back briefly, you can see here when you compare this patient's mediastinum compared to the prior, here it's very well centered. And now you can see that there is shifting to the left side. So that's one of the classic things that we look for is mediastinal shift. But one of the things that's not talked about very often is depression of the ipsilateral hemidiaphragm. So in the setting of a tension pneumothorax, the air can accumulate so much that it actually pushes the hemidiaphragm downwards. So here you can see how much lower the right hemidiaphragm is compared to the left. And that was a new finding compared to the prior. And this is a sign of tension pneumothorax itself. So always look for that, whether you're dealing with a supine radiograph or an upright radiograph, and comparing to priors, because occasionally the only finding you may see is just ipsilateral depression of a hemidiaphragm. So how does patient position affect the presentation of pneumothorax? And this is why it's important to know whether it's supine or upright. When you have a supine radiograph, you're going to look for the deep sulcus sign for a pneumothorax, and you're not going to see that classic pleural line that you see in the lung apex. In an upright radiograph, you'll look for an apical pneumothorax, and you'll see that pleural line along the top that indicates that the lung is partially collapsed. So being able to appreciate whether it's supine or upright is very important. Okay, so this is case 6. Let's see how we're doing on time. I know we're getting close to the end, but I do want to go over this case because I think this is a very good one. So this is a patient that was presenting with shortness of breath. Now, when you look at this radiograph, it looks pristine, right? This looks like a normal chest radiograph. And if you're thinking that, then you are correct. This is a normal chest radiograph. So let's take a look at this patient CT. So they had come to the ER with shortness of breath, and they had this normal X-ray. And so the ED physician opted to get a chest CT on this patient. And specifically, they decided to get a contrast-enhanced pulmonary embolism protocol, CTA. So for those of you astute radiologists, I'm sure that you've right away noticed that this patient actually has pulmonary emboli. They have filling defects that are present here in the right distal right main pulmonary artery, as well as in the left upper lobe, and possibly in the distal left main here. Okay, so once you've identified a PE, the finding that has the most effect on severity of symptoms and patient prognosis is what? Size of pulmonary embolism, right ventricular enlargement, left ventricular enlargement, or presence of PFO. So I want you to vote and then we can see what the majority of the votes show.
So majority of votes have come for B, the right ventricular enlargement.
Excellent, excellent. That's exactly right. So once you've identified a PE, the finding that has the most effect on severity of symptoms and patient prognosis is right ventricular enlargement. Excellent. So let's talk about that in more detail. Okay, so when we look at this CT, we see right away, all right, the patient has a PE. The very next thing you should do, if not even before, is you want to look at the right ventricle, right? So you want to see, is my right ventricle enlarged? And there's different findings that you can see with the right ventricle. So let's talk about that. So when you look at the right ventricle, essentially what you're looking for is evidence of right heart strain. And the reason this is important is because patients can die as a result of right heart strain. So the findings that you're specifically looking for are straightening of the intraventricular septum. So when you look at the septum here, this is your left ventricle, this is your right ventricle, and normally the left ventricle is larger than the right ventricle. And if anything, this left ventricle bows in toward the right ventricle. Well, in this situation, you can see that not only is the left ventricle not bowing into the right ventricle is actually bowing in towards the left side. So sometimes you can have this be completely straight, or sometimes it can even bow in, and that's a sign of right heart strain. The other finding that you can see is this increased RV to LV ratio. And ideally, this would be performed in end diastole, but most PE protocol CTs are not performed cardiac gated. So you don't know whether it's end diastole or not. But if you look at the level of the valves and you measure the right ventricle compared to left ventricle, for most people, this ratio is approximately 1 or lower. There's different ratios you can use. The higher you go, the more specific it'll be. The lower you go, the more sensitive it'll be. If your ratio of your right heart to your left heart is greater than 1.2, that's quite specific, then you have a very good chance that you're dealing with right heart strain. So in this case, the ratio was 2.2. So this was 2.2 times greater than the left ventricle. So this is definitely indicative of right heart strain. And we see the bowing of the intraventricular septum toward the left. The other finding you can look for in right heart strain is reflux of contrast into your intrahepatic IVC. So the contrast, oftentimes it may go slightly into the IVC, but when it goes fully into the intrahepatic IVC and these veins here, that can indicate right heart strain, because the contrast can't be pushed forward through the right heart because there's so much extra pressure that is being built up. Now, this is not specific, right? So if the patient had tricuspid regurgitation, that can also push contrast back. But when you look at these findings together, that's very suggestive of right heart strain. Other things that you can look for is right atrial enlargement, or if your azygos vein is acutely dilated or very dilated, that can also indicate right heart strain. So I took out a lot of slides to kind of talk about this in more detail. But the reason, like I said, that this is most important is because right heart strain is an independent predictor of mortality in the setting of pulmonary embolism. So size does not necessarily indicate whether or not a patient is going to have complications or die from a pulmonary embolism. So you can have a very small PE, but if they have right heart strain, they are much more likely to die from the pulmonary embolism than if they had a saddle pulmonary embolus and no right heart strain. So this really is the most important finding to look at and to discuss. And if a patient doesn't have right heart strain and they meet criteria for low risk PE, oftentimes they can be given outpatient medications and discharged. Whereas as soon as you see right heart strain, that patient needs to get admitted to the hospital. And so at least that's the criteria that we use in the United States. And so it's important to understand that as the radiologist, you're actually guiding management. Whether or not you call right heart strain might decide whether or not this patient gets admitted to the hospital. So being able to accurately recognize this is very important as the radiologist. So in summary, and I apologize for going a few minutes over. So let's see here. Let me bring this over here. So when you describe opacities, you're going to describe them as either consolidative or ground glass or mixed. You don't want to use the word reticulonodular. That's not a helpful descriptor. Remember to use contrast when you have pleural diseases or paramediastinal masses. Don't give contrast for simple pulmonary nodules. When you have patients that have acute symptoms and an acute radiographic change, don't forget to think about lobar collapse. And this is one of those findings where oftentimes outpatients may present with lobar collapse. And if you're not thinking about it, this is a very easy diagnosis to miss. Think about tracheobronchomalacia in a patient that's received repeated courses of steroids for shortness of breath without any improvement, and typically in the setting of a normal chest CT. The appearance of a pneumothorax will change depending on where the patient, how the patient is positioned when the imaging is performed. And right heart strain is the most critical factor to evaluate in the setting of pulmonary embolism. So hopefully these cases were helpful. I know that most of you got many of the cases and questions correct. So hopefully this was helpful. And I'm definitely open for any questions that you might have.
Thank you, Dr. Bixi. Dr. Abhishek here. There are few questions. I'll place it here. The first is how to differentiate between the cavity for TB versus malignant.
How do you differentiate? Yeah, so differentiating, this is a great question, because when we think about it as radiologists, one of the things that's very tempting is, I'm seeing something, I need to make the diagnosis. And it's important to understand what your limitations are. So when we look at cavities, we're not necessarily able to say, well, it's due to this specific cause. One of the things when you look at a cavity is, am I dealing with something benign, or am I dealing with something, when I say malignant, I mean like malignant from either a cancer or from a severe infection? Is it more acute versus chronic? One of the most important things to look at when you look at a cavity is the actual wall itself. So the couple things you're looking at is, how thick is my wall? And the other thing is my wall very nodular? Because that's going to indicate that you might be dealing with an acute process that's going on. Once you identify that, the couple of other things that I start to do at that point is look and see, do I have other findings in other parts of my lungs? Do I have other nodules that are present? Do I have lymphadenopathy? And what does that lymphadenopathy look like, right? Because the lymphadenopathy that you see with TB can look very different from that in malignancy, but they can often look the same. And then, when we do chest CTs, we also get the adrenal glands, right? And lung cancer loves the adrenal glands. So I always look at the adrenals to see, do I have something that looks like a metastasis to the adrenal glands, or even portions of the liver? But the point I'm trying to make is that you often can't differentiate whether it's from malignancy or from tuberculosis. So the point is that if TB is on your differential, you want to isolate that patient, right? It's very easy to isolate them, get some sputum cultures, and rule out TB, as opposed to saying, well, I think that this is a malignancy, and you don't really either mention TB or you put it lower on your differential and they don't isolate the patient, and then all of these other patients get exposed. So you can't confidently differentiate it as a radiologist. You can certainly have more suspicions based on whether you see more tree and bud nodularity, the type of lymphadenopathy and the clinical history, but you can't confidently exclude one or the other. Does that answer your question?
Yeah, I'm sure.
Okay.
And the other thing is, which all other conditions are there where we can have a reflux in IBC?
I'm sorry, could you repeat that question?
Which all other conditions are there which can show reflux in IBC?
Yeah, and I think maybe I had answered that one. Yeah, so tricuspid regurgitation would kind of be the most common situation. The other point that I want to make is that a lot of times patients may have chronic right heart failure, right? So if you have chronic right heart failure and you get a pulmonary embolism, they may already have reflux into the IVC, right? Because their right heart is already not working, and they might have a very large right ventricle and a very large right atrium. So one of the key ways to differentiate, am I dealing with acute right heart strain versus chronically elevated right heart pressures, is looking at the pulmonary artery. So when you have acute right heart strain, your pulmonary artery is not going to enlarge. It takes a long time for your pulmonary artery to remodel and enlarge. And so when you see a very large pulmonary artery with what looks like right heart strain, this patient might have chronically elevated right heart pressures. And so you may not be able to tell for sure, well, do I have acute on chronic right heart strain? But typically patients that have chronic right heart failure, and they have a pulmonary embolism, they're already going to be at a higher risk of mortality. So those patients you wouldn't want to discharge either way. But looking at that pulmonary artery can help you differentiate it. But in terms of answering your question, tricuspid regurgitation is kind of the most common situation in which we see. And often those patients may have underlying chronic liver disease as well.
Yeah. Okay, the next one is how to measure RV and LV ratio.
Yeah, that's a great question. And, let me go back to that slide because I didn't show you, I was trying to keep this a little bit more general. But I give another version of this that has a lot more details. So honestly, in this, the other version of this lecture that I have actually has all the references for exactly how to measure this. I would say for the purposes in general, when you're reading a PE protocol CT, and you want to very quickly look at the RV to LV ratio, you want to scroll down to the level of the valves, right? So you want to scroll down to the tricuspid and mitral valves, and you can measure it there. Now, the problem with this is that it's not very sensitive or specific, right? Because a lot of times patients have RV to LV ratios that are very close to 1. I mean, some people use the cutoff of 0.9, others use 1.2, which is what I tend to use because I think it's more specific. Otherwise, you're calling right heart strain in everyone. But what I do, and if you know how to do this and you have the ability to do this, this is what I recommend. We have basically it's like an independent workstation that's linked to our PACS system that allows you to make 3D measurements. We use something called Philips IntelliSpace Portal, but you can use any version of this sort of portal where you can essentially pull up the images in all 3 imaging planes, and you can manipulate the images so that you can get a perfect orthogonal. So what you do is you line it up on the coronal image and you line it up on the sagittal image so that you're pointing directly through the apex of the right ventricle. And then you go back to your axial image to create a true axial. Because right now, when you look at axial images, it's an axial through the chest, right? But it's not an axial through the heart because our heart isn't perfectly straight in the chest. So when you're cutting the patient into slices on an axial CT, the heart is oriented obliquely. So you can falsely get an increased RV-LV ratio. So what that volume viewer, that 3D volume viewer allows you to do is it allows you to create axial images to the heart itself so that you're cutting through the heart at a perfect perpendicular level, and you can accurately compare the right heart to the left heart. So if you have access to that, that would be the best way. And at this point, it takes maybe extra 10 to 15 seconds to quickly line it up on the portal and get that accurate measurement. And that would be the best way if you have access to that. But if you don't have access to it, yeah.
Sorry, go ahead, please.
No, I was just gonna say, but if you don't have access to it, this is how I would do it on the straight axial at the level of the valves. Okay, go ahead.
The next question also related to it. Do we apply similar criteria for right heart strain in a non-embolic pulmonary hypertension cases?
In non-embolic pulmonary, so you just mean straight pulmonary hypertension?
Yes,
well,
yes.
Okay, so here's the thing. So when we're dealing with pulmonary hypertension, essentially what that means is that the pressure in the pulmonary artery is abnormal, right? So you've got elevated pressures in the pulmonary artery, and the gold standard for diagnosing that is right heart catheterization. Now, you can suggest pulmonary hypertension on a CT based on the size of the pulmonary artery. And typically, when you're looking at a CT scan, very briefly, the way that you might suspect that they have pulmonary hypertension is the size of my pulmonary artery larger than my aorta? If it is, then you'll often measure it. And again, if you can do those orthogonal images on the volume viewer, that's great. And, there's charts available for based on this patient's age, their sex and their body surface area, how large should their pulmonary artery be? And if it's enlarged, let's say you're getting a pulmonary artery measurement of 40, right? That's not going to be normal in anybody. Then typically what I'll say is that the pulmonary artery is enlarged, which can be seen with pulmonary arterial hypertension. The other situation in which pulmonary arteries can often be enlarged is if you have a shunt. So it doesn't mean that they have to have pulmonary hypertension, like that the pulmonary hypertension is the primary issue. They might have a shunt that needs to be fixed. So pulmonary hypertension is, I guess, to answer the question, that's a separate diagnosis. And so whether or not their right heart is enlarged in that situation, I guess it's kind of superfluous, right? So does it matter whether or not their RV to LV ratio is increased in the setting of pulmonary hypertension? Well, if you already know they have pulmonary hypertension, we know that at some point the pressures are going to increase in the right heart. So it almost doesn't matter whether or not your RV to LV is increased. Does that make sense?
Yeah, definitely.
Okay.
Yeah,
And
yeah.
I'm happy to answer that further because I know that's a complicated situation. But the
Yeah.
point is, if you have pulmonary hypertension, you already know that your RV is eventually going to be increased. You're not necessarily going in there trying to measure an RV-LV ratio. The reason we do that in the setting of an acute PE is because these are patients that don't have pulmonary hypertension, and this might suddenly cause them to go into sudden cardiac death.
Agreed.
So,
Yeah.
okay.
We have one viewer from Ethiopia, and the question is can we diagnose confidently the diagnosis of NTM in a cases of upper lobe cavitary lesions?
No, you can't confidently. And I mean, this is true for most things in radiology. You can't confidently diagnose it. So the situation, with nontuberculous mycobacteria, and again, this is going to depend upon where you're practicing in the world. When I see nontuberculous mycobacteria, the classic situation in which I see it is I see it in the right middle lobe, and I see it in the lingula, and I see it in patients that do actually have tree and bud nodularity. And it's typically middle age or older women. So I would say, let's say you have a 65, 70-year-old thin woman with right middle lobe and lingular cavities, tree and bud nodularity. That's overwhelmingly likely going to be non-tuberculous mycobacteria when I read that CT. Now, what's considered the classic version of NTM is patients that have underlying structural lung disease like COPD, sarcoidosis, any sort of upper lobe lung disease. And as a result of that, they become secondarily colonized with non-tuberculous mycobacteria. And that's where you see that in the upper lobes. Now, the thing is that what's very important in this situation is knowing, well, what's the demographic of my patient and what's the clinical history? And so, with NTM, patients also present with fevers, chills, night sweats, and usually those symptoms are very chronic, right? They'll have those for many months and years, which you're not going to see that in the setting of TB, right? Patients would rapidly progress in 6 months or a year if they had tuberculosis. So using your clinical history is going to be important. And that's why you can't confidently say, this is going to be NTM, this is going to be TB. You have to put all of those things together. And it really emphasizes the point that as a radiologist, if you want to make the most difference, you have to either look in the chart and see what the history is or talk to your clinicians in order to arrive at the most probable answer.
I think we have covered most of the questions, Dr. Bixi, and thank you so much for a wonderful talk. It was really amazing, and the collection of cases were really outstanding. Thank you so much, and looking forward to have more talks with you. Thank you so much.
Yeah, I would
Absolutely.
also like to thank you so much. Actually, my network issues were there, so Abhishek really helped me. So thank you, Abhishek, also. And I think it was an
Thank you.
amazing lesson. There were so many teaching points in it that I can't even tell you. It was really, really amazing. I really enjoyed it. Thank you so much.